Thanks very much for the very kind invitation to give a brief overview of treatment for relapsed neuroblastoma. You can see below my conflict of interest statement, and this is again another note. This is aimed to be an overview, not a systematic review. When I was starting to prepare this overview of what has happened in relapsed neuroblastoma, I thought if I lived in an isolated island and would only go to ANR every 2 years, what is new? What is to be said about relapsed neuroblastoma that we have learned over the past 2 years? And when you're preparing for such an overview, it's very difficult to give a balanced vision. There are a lot of things, with time, a lot of things happen, so you can always be very pleased that a lot of things are happening because time goes. As you get older, on the other hand, you become more grumpy in general, so you tend to be more critical with things. So I think I hope that I'll be able to give a positive and negative overview of treatment for relapsed neuroblastoma. There is definitely a lot going on. There are a lot of improvements and achievements. Unfortunately, still the vast majority of patients, of kids with relapsed neuroblastoma, still die. So actually, we're not there yet, and there's a lot to do. This is what I'll try to cover during today's presentation. And I wanted to give a couple of notes before of how do we treat relapsed neuroblastoma and where we are. This is a study that Wendy London undertook with the INRG database, just to tell us that those with stage 4 and MECAN amplification that have a relapse are the ones that have the worst outcome. If you have a stage 4 older than 18 months, and you relapse, your 5-year survival is 8%. If you have a MECAN amplification, your survival is 4%. So that's really low and quite a bad starting point. There is some other data that has come afterwards about outcome and relapse. There is a study by the Italian registry showing the survival for patients that relapse or progress with high-risk neuroblastoma, and there's another study undertaken in the UK here for the first time showing a bit of an increase with time, where patients diagnosed after 2000 have a bit of a better outcome, and at least there are some long-term survivors. This is only to highlight that we, in the relapse, in the frontline setting, we use the big trials as registries or to feel how the patients are doing. But in the relapse setting, this data is not available. We actually don't really know well what happens to the patients when they relapse and what's their long-term outcome. We have been doing relatively short-sighted trials centered on the drug. This is the drug I want to see, this is the response rate, or this is the toxicity. But actually, we don't have the big picture of what happens to the patient, and that's where the collection of real-world data remains very important. This is how we treated relapsed neuroblastoma approximately 5 years ago. You have a relapse, high-risk neuroblastoma. It's incurable disease. You would give the patients some form of chemotherapy. A significant proportion of them would respond or stabilize their disease, and then depending on the physician preference, they would continue on chemotherapy. There are patients that have been on chemotherapy for relapsed neuroblastoma for 3 years, for 5 years. Some would give MIBG therapy or other types of consolidation, such as another stem cell transplant. Patients that had a second progression or relapse would go on phase 1 trials or receive palliative care, depending on their situation and the availability of new drugs. Well, where are we today? At least there are a number of major achievements. I think first, we have incorporated molecular profiling, and I'll discuss that a bit later, but we are conducting molecular profiling of all children with relapsed neuroblastoma. We have incorporated immunotherapy, so starting by using it as another consolidation tool, and that's the long-term infusion trial that COPEN has presented before during today, but also the very interesting data seen this morning with the combination of dinutuximab with chemotherapy. So immunotherapy with anti-GD2 monoclonal antibodies, but also with other forms of immunotherapy is incorporated in the treatment of relapse disease. And in terms of phase 1 trials, we have improved in the design and the portfolio and the number of drugs that are available. But what do we have to work on for the future? What are our limitations at the moment? I said that we are doing molecular profiling. We're doing molecular profiling, but the number of drugs that are available is quite limited. So actually, there are a lot of molecular aberrations that do not have a tractable a drug that you can use for patients. Also, there has been in this time a lot of negative single-arm trials and a lot of drugs that have been tested in phase 1 trials but are not then fully developed, so we can't use them. And I think the final point, which is centered in this part, but in general, is that we don't have a clear pathway, a clear strategy for the whole relapsed neuroblastoma. Same that we have a very clear idea that for frontline treatment, we want to do induction, consolidation, and then minimal residual disease type of treatment. We don't have that idea of where to put the different treatment modalities in kids with relapsed neuroblastoma. Obviously, we start with chemotherapy and MIBG therapy. There is an endless list of single-arm phase 2 trials, and this is just a summary of some of them. Temozolomide combinations, topotecan combinations, doxorubicin, ICE. There are a number of combinations. All of them have some response rate. We don't have a lot of data on the impact of these modalities in progression-free survival or overall survival, and that's one of our needs. And this is an example of a piece of work that we're trying to do, putting together data from the temozolomide TVD and topotecan temozolomide trials that COPEN and ITCC have conducted together. These trials, in general, stop collecting the data very early, and they go to publish data on very short-term endpoints, such as response rate, and we don't know what has happened to the patients. So we try to establish what is the baseline for first relapse patients that have participated on trials to establish their progression-free survival, their overall survival, their chances of response, when they respond, how long does it last for, and clearly separated two populations of children with refractory and relapsed neuroblastoma that have to be taken into account separately when analyzing these results. Strikingly, there are very, very, very different response criteria used in these trials. Each of them has a different response criteria, making comparing them quite difficult. And thankfully, Julie Park presented as well in this ANR the new international neuroblastoma response criteria that will help us evaluating all the patients with the same criteria. We tend to use response rate as the endpoint for phase 2 trials in relapsed neuroblastoma. You can question whether that is the best endpoint or not. It is definitely something that you know in the short term, but it is very difficult to evaluate for neuroblastoma because you need MIBG, your CT and MRIs, and there are discrepancies. And in the end, it doesn't matter that much to the patient as far as the patient is alive and progression-free. So we might need to revise whether our preferred endpoint is response rate or whether that is a good surrogate for what happens afterwards. And we have tended to have short follow-ups. MIBG therapy, as well, Julie Park mentioned it. This is a meta-analysis that the GAZE group from London did on all the trials that had been published for MIBG therapy. And you can see this is the response rate reported in the trial with its confidence interval. So it's clear overall the response rate was between 20 and 40%, even higher if you took some newer studies. So there's definitely a role for MIBG therapy, and it is being evaluated in frontline randomized trials in both sides of the Atlantic. But we also need to know at relapse when to give it, how to give it, and compare it to what we are with the alternatives that we're doing. And there are new combination studies nearly finished or ongoing, mainly by NANT, by the NANT consortium. We also have improved in having a strategy for new drug development. This is a slide of the NDDS project that was started in Europe to put together, start working together, biologists, researchers, clinicians, statisticians, regulators, to have a common strategy on how to develop drugs for each specific disease, and neuroblastoma in this case, that could help the regulators, pharmaceutical companies, and improve the collaboration. And as we presented, we started this in 2012, defined 6 targets, that were top priority, and things are starting to happen. Obviously, these targets, some of them have not moved at all in this time, but some others have trials ongoing, and we are having more drugs available. So obviously for ALK, you know that there are several trials with several ALK inhibitors ongoing, but we need some strategy and prioritization there. You know that for MDM2 and BRC5, there is a lot of preclinical work done, but no trials yet. For mTORC1 and 2, the first combined inhibitor, AZ2014, will start to be tested in the European ESMART trial. Aurora kinase, you have heard as well this morning, the development of alisertib done by the Children's Oncology Group and the US, and the CHEK1 inhibitors are again in development. There is a lot of new targets joining in, and you will have heard during this ANR about epigenetics, ATRX, etc., and immunotherapy. This is a dynamic process where we continuously review the data and work together with the European Medicines Agency and industry to be able to deliver more drugs into neuroblastoma patients. And that is, in summary, that's the new model that we want to work towards. It's called the Mechanism of Action Drug Development Model, and it's just been recently published by Andy Pearson in European Journal of Cancer. I think one of the highlights of this model is that the ones that have devised the model are academic researchers, pharmaceutical companies, European Medicines Agency, and parent organizations. So all together, they've sat and thought what is the best strategy that we can have to develop new drugs. Definitely need to be based in very, very strong knowledge of biology of cancer, need to consider all hallmarks of cancer, so attack all possible cancer vulnerabilities, include tumor profiling and molecularly targeted therapies that match the patient's tumor aberrations, have a better selection, have a higher bar to take the drugs into clinical trials, have more efficient early phase 1 dose-finding trials, and very much pursue randomized phase 2 and phase 3 trials so that we can take more drugs into clinical practice. And here we have a couple of examples. If we take the view not only of us as academic investigators, but the pharmaceutical companies that have to develop the drugs, the regulators that have to mandate or waive the need for pediatric development for each of the drugs. For example, for ALK inhibitors, there are at the moment 5 ALK inhibitors in development, two of them already two already approved for adults. How do we want to develop these drugs for children? ALK aberrations in pediatric cancers are quite rare. They are very important in neuroblastoma, but overall, they make a very small number of patients. So we can't have 5 clinical trials of ALK inhibitors. But on the other hand, we can't have no trials of ALK inhibitors. So we are working to see how we can prioritize these agents. And here you can see another example with PD-1, PD-L1 inhibitors that are in clinical development. There's a huge success of these agents in many adult cancers. Everyone is very excited about it. We want to test them in pediatric cancers and in neuroblastoma. But again, there are 5 inhibitors in development. 2 of them are already approved. A third one got a breakthrough designation. So we don't need to do 5 first phase 1 trials of one for each of them, 5 phase 2 trials. There has to be a way of working together to select which ones we want to develop for pediatrics. So that's the summary. We now, I think that we now have a good drug development strategy. The next question probably for the next ANR or for the subsequent one is, will it deliver? At the moment, it is delivering in more drugs and more efficient clinical trials, but actually we needed to deliver into better outcomes for the patients and more drugs that are taken to phase 1, to frontline, and we're still not there. But we also need another strategy, which is what is the patient pathway to treat relapsed neuroblastoma? Do we need something similar to frontline with induction, consolidation, maintenance to work towards that? A few comments about molecular profiling. This is new. I think 2 years ago it was not that clear, and definitely 4 years ago it wasn't. Now there is agreement that patients, where possible, patients should be rebiopsied at the time of relapse and molecular profiling be conducted. The majority of big institutions across Europe, the US, Australia, Japan, etc., are already conducting different next-generation sequencing platforms to identify genomic aberrations. We need to rebiopsy the tumors at relapse because the genomic aberrations can change, and that can offer access to targeted therapies. Depending on the bar that we set for these genomic aberrations, we can be very selective and only identify very, very strong oncogenic drivers. So then we will have very few patients, but with very high chances of benefiting from the treatment. If we were only selecting patients for BRAF mutations or other known very strong oncogenic drivers, we would have very high success rates. But on the other hand, or we can be less selective and have some enrichment, some selection, but then we should expect less success. Still, we find many genomic aberrations that are not druggable. We find druggable ones, but where the drugs are not available for children. So there's a lot of work still to be done in this aspect. There are a number of collaborative academic and private platforms to perform these analyses that have been developed. And again, I insist that not because it is molecularly driven is not necessarily good. So we need to prove in a few years' time that this approach targeting the patient's aberration with matched drugs, it actually makes a difference in improving the patient's outcome. These are just a few examples. For example, the French presented their first experience in ASCO last year. So they recruited their first 12 pediatric patients in 1 year. This is all solid tumors, not neuroblastoma. 9 of them were eligible. The other 3 couldn't enter the study. 6 had druggable aberrations. And in the end, 2 patients were treated with a matched therapy. So there is a lot of attrition. There was a lot of patients that progressed very early or had no drug available. This is another example that was presented this year. This is ACCE is a clinical trial using crizotinib and other drugs for patients with ALK, MET, and ROS aberrations. So they screened 107 pediatric solid tumors in 2 years. 18 of them had aberrations. Only 11 of them got to get any treatment. Only 8 of them were available. Only just 4 of them had a response. So we just need to learn how to evaluate these patients, how to define what is success or not. Obviously, if you say 4 responders out of 8, that is 50% response rate for a relapsed population. That's relatively good. If you say 4 divided by 11, 4 divided by 18, 4 divided by 107, then it depends how your success rate will change. In this ANR, also Jan Molenaar presented the results of the, well, not the results, he presented the process of the ITER study, which is the Dutch molecular targeted program. And I think the very good learning point there is that there are several steps that you need to take before jumping too fast on giving drugs to patients with molecular aberrations. There is a step with technical development to have a robust platform. There is another phase of feasibility. Can you do it real time? How long does it take to get the results? How do you get the results to the clinicians? And then in the end, you start giving the patients much targeted therapies. And the lack of drugs from molecular programs is what took the ITCC to develop this new trial that will start during this year called eSMART. Because the majority of patients will not have access to a registered drug or access to a phase 1 clinical trial of a new drug. So you would have your in this study, you will have your molecular profiling program, the results processed by a molecular tumor board, including both biologists and clinicians. And when you find actionable targets, you could use drugs if they're registered. You could just buy them and give it to the patient if they're registered. Use the portfolio of ongoing phase 1-2 trials that are available, or have a trial where, depending on your molecular aberration, you go to different arms of different new inhibitors. Some patients will have no actionable targets, so they should go to other ongoing, more generic phase 1-2 trials, or to non-targeted arms of the ESMART trial. It's just trying to match the need of the patients for more targeted drugs. And finally, I wanted to touch briefly on what's new, what is around about new targeted therapies and immunotherapy for relapsed neuroblastoma. I took this slide from Andy Pearson that used it when he gave a similar talk 2 years ago. These were the studies that had been done by ITCC in Europe and had been completed. So we had completed a phase 1 trial of ridaforlimus, a phase 1 of an aurora kinase inhibitor, and a phase 1 of dalotuzumab and an IGF-1R inhibitor. The 3 of them were, the development of the 3 drugs were discontinued by the company. So it was the first sign that we were doing more trials and completing them, but still a sign of the big attrition that we see often in drug development. So we needed to increase the portfolio with molecularly targeted agents. And this is a snapshot of the trials that have been recently completed that could have any role for neuroblastoma, and that includes both sides of the Atlantic. But definitely the number of targeted drugs that have completed phase 1 is enormous. We have seen results of the COG anti-GD2 temsirolimus trial, of the alisertib temozolomide irinotecan trial, DFMO, bevacizumab and temozolomide irinotecan by Memorial, all in this meeting, of combinations of MIBG with haploidentical transplant, with vorinostat, with chemotherapy, and about immunotherapy, without going too much into detail again, there is the LTI antibody trial from COPEN, the Sanjut antibody trial, lenalidomide, vaccines, oncolytic virus, CARS. The number of, at least the number of therapies that we are developing for neuroblastoma is outstandingly good. I think another good reflection, if you look only at the phase 1 therapies, the ones that are in red are those that have progressed to phase 2 or to phase 1B or phase 2 in neuroblastoma. So before, there was a lot of drugs, either some drugs, for example, like regorafenib, lenvatinib, afatinib, they are inhibitors where in the phase 1 trial, they were generic phase 1 trials, so any patient with neuroblastoma could also enter. But in the end, they were not drugs that we wanted to develop for neuroblastoma. But in these past 2 years, we have completed a study of nab-paclitaxel, of LDK378, which is the Novartis ALK inhibitor. Crizotinib has moved forward to be combined with chemotherapy and is moving ahead in its use in the US. And alisertib, again, is a nice example. This aurora kinase inhibitor. The phase 1 was completed. The phase 1 in combination with chemotherapy was completed. The phase 2 of the combination with chemotherapy was reported this morning at this meeting. So that just shows that we're not only testing random numbers of drugs in phase 1 trials, but these are more relevant for neuroblastoma, and they are moving forward and being used in more patients. And just to finalize, this is an analysis that we have made as well in ITCC. We have analyzed all the patients that we have treated in phase 1 trials, in first-in-child trials in 8 ITCC centers. We treated 270 patients that were covered in this analysis. And this is just to show that 33% of them were neuroblastomas. That's 12% of all solid tumors. That's 23% if you take only the non-CNS tumors. And it is for you to judge whether that is a lot or not a lot, whether we could have treated more patients. Neuroblastoma is one of the leading causes of death and one of the leading solid tumors causing death in children. So actually we perhaps should still do a bigger effort so that these numbers are better, because there are not that many patients treated in phase 1 trials for ITCC. We know that the median survival for neuroblastomas in phase 1 was 11 months. There were still a proportion of patients that responded, another proportion of patients that had disease stabilization, so there's more and more options. I think I'm quite pleased to say that for the first time in history of the relapsed neuroblastoma, there are 3 ongoing randomized trials for relapsed neuroblastoma. 3 of them. The 3 bigger cooperative groups in the world have a randomized trial at second line at relapse for neuroblastoma. There is a COG trial that was presented this morning by Rajan Modi with a 53 objective response rate for anti-GD2 plus temozolomide plus irinotecan. This is a randomized trial, but does not compare between the arms because of its design. Each arm compares to itself. There is a RIST trial in Germany going on, testing irinotecan, temozolomide, with and without dasatinib and rapamycin, and that trial is ongoing. And in COPEN and ITCC, there's the Beacon neuroblastoma trial, which is more or less halfway through, and not only we have, it is halfway through, but we have presented not only one abstract with how is it going for the moment, but we've presented another abstract with the next trial that we already want to conduct, which is again another randomized trial for relapsed neuroblastoma. So these are the take-home messages that I wanted to highlight. We do have a drug development strategy. We have new therapies that now cover all hallmarks of cancer. So these includes targeted agents for many different targets, as well as immunotherapy. We are delivering in numbers of phase 1 trials, but also how they progress to phase 1b, phase 2, and randomized phase 2 trials. And we are improving the trial design and methodology. But we don't have an overall strategy for relapsed neuroblastoma yet. And definitely, there are still a lot of patients that need new therapies to have a better outcome. So I hope I've finished giving a bit of a balanced view on what is missing and what has to be done, what you all have to do from here to the next ANR. I'd want to finish acknowledging, again, giving big thanks to the organizing committee of ANR for inviting me, to Andy Pearson for his mentorship, my numerous institutions where I work and have worked, the guys where I work with in Madrid and ITCC and COPEN, the patients and families. Thank you.